My name is Kristen Desjardins. I work at the Napa Center. Today I'm going to be talking to you guys about feeding and eating after traumatic brain injury, specifically with regard to the concepts of motor learning and neuroplasticity. I'll go through this really quick. Some of the things we're going to try to do today are identifying the potential impacts of a brain injury on feeding and eating, understanding what principles of motor learning are and what neuroplasticity is as it relates to feeding and swallowing intervention. We're going to talk about some therapy techniques and approaches that can help build skills, and then understanding some of the pillars that are driving our intervention decisions as therapists. So first, I am going to talk just a little bit about feeding and swallowing, the anatomy and physiology of it a little bit, just so that you understand the complexity of the feeding and swallowing systems. So feeding versus eating, a lot of times when you think about feeding, you think about a parent feeding a child. When we're talking about feeding today, we're talking about tube feeding, just essentially offering nutrition to somebody who can't eat independently, and the food is going to bypass the oral, pharyngeal, and esophageal cavities of the body and go straight to the stomach. And in these little diagrams up here, we have, let's see. So on this one, this is an NG tube. A tube is named based on where it originates on the body. So a nasogastric tube is going to insert in the nose, and then it goes straight to the stomach. So it bypasses the mouth and the esophagus. And then we have a G tube over here. That's a gastrostomy tube, which inserts directly through the abdominal wall into the stomach. And then a J tube is it attaches into a portion of the intestine. So depending on the child's needs, whether their stomach, their intestines are functioning properly, that's where the tube is going to be placed. And a lot of times NG tubes are just a temporary tube. We want to kind of move to one of the other ones, just because having a tube in your nose and your throat for a long period of time can be irritating and kind of cause some aversions to eating. And then when we're talking about eating, we are talking about the process of taking food by mouth. So it might include being fed by an adult, but it's going to be actually utilizing all of the different oral, pharyngeal, and esophageal cavities to process the food. So we're going to talk on the next stage about these phases of eating. So there are actually 14 different physiological components that occur within these 3 stages of swallowing. I've only kind of highlighted some of the main ones here for you. We're not going to get too technical on it today, but the first one is the oral phase, and that's what we see here in diagram 1. This portion of feeding is when you are just controlling the food and liquid. You're using your lips, your tongue, your teeth, and your jaw. And it is when your tongue starts to move the food towards the back of your mouth. You can see here in this diagram, the blue line is airflow. So during this phase of eating, you are able to breathe at the same time. This green spot is the bolus of food. And then the second phase is the pharyngeal phase. So during this phase, the airway starts to close off. The swallow is triggered, and the food is beginning to move its way to the esophagus. In this phase, all of the movements that happen are completely involuntary, and they occur strictly through reflexes. So we don't have any conscious control over what is happening here. It's pretty complex. The soft palate has to elevate and close off the nose. There's a flap that folds down and covers the airway, and the food makes its way to the esophagus. During this phase, you are not able to breathe. You can see the air. You probably wouldn't even breathe in during this phase because you are working on eating. And then finally, the third stage is the esophageal phase. This phase starts when the esophagus closes back and it begins to squeeze or deliver the food down to the stomach. And in this phase, the airway reopens. During this phase, with food, it kind of takes a peristalsis action, a squeezing action to move that food down. With liquid, it mostly just drops its way by gravity to the stomach. So feeding assessment is used to determine whether or not a child is safe to eat by mouth or which areas of development related to feeding and eating are impacting their ability to functionally eat and participate in meal times. A feeding assessment is going to include a case history, and in a case history, we are looking to get as much detailed information on the child's medical status, diet, feeding schedule, environmental routines, pretty much any information that we can get. A lot of times you'll probably hear a feeding therapist asking you questions and you have no idea why they relate to feeding, but the entire body, all of the organs are involved in some way in the feeding process, so we want to kind of get as much of a global view of the patient as possible. So after we get a case history, we're going to move on to a clinical feeding observation or evaluation, and this is when we're just going to watch the child eat so that we can see what their oral motor skills are. Are they able to chew and swallow? Are they having any coughing? Things like that. On a clinical feeding just observation, a bedside evaluation, we cannot tell if a child is aspirating or not. We may see symptoms of them coughing or choking or things like that, but we cannot tell that just from looking at them. So we occasionally use an instrumental swallowing evaluation, and there are two different main types of those. So one is, it has two names, a video fluoroscopic swallow study or a modified barium swallow study. And that's what this top diagram here is. It's an X-ray that takes some short video clips of the swallowing in process. So we're able to see either from the side view or the front view what is happening inside, and we can visualize whether or not food or liquid is entering into the airway or if it's making its way appropriately to the stomach. You can see this dark spot in here is the food moving through the esophagus in this photo. We mix a substance called barium with the food or liquid so that we are able to see it on X-ray. The other swallowing evaluation we do is a fiber optic endoscopic evaluation of swallowing, or a FEES. And this is what this bottom picture is. We take a small camera and we insert it through the nose, down the back of the pharynx, and or the throat, and we can get a view of the airway and the top of the esophagus to see what's happening during the moment of the swallow. This is a top view, so this open circle is the airway, and then this little U-shaped white structure is the epiglottis. It's the little flap that covers the airway when the swallow happens, and then the esophagus would be behind this. It would open up. There's a sphincter at the top that holds it closed, so that would open up during the swallow. So they both give us different information about what's happening during the swallow. The FEES does not expose children to radiation, so sometimes people prefer that, but either can be used. So this is the hierarchy of feeding. This is how we as therapists are looking at feeding as a whole. Like I talked about earlier, there are a lot of components to the feeding process. So a lot of times parents come in and just want to start talking about like what's happening with the mouth, but we really got to start at the very beginning and look at all of their body systems and make sure they're actually ready to be eating by mouth. So at the bottom, we look at their medical and physiological stability. We want to make sure that their body is in optimal functioning mode. It's called homeostasis, the condition of optimal functioning. This means that our basic needs are being met. We're breathing, we're comfortable, we're happy. And if kids aren't sort of in this mode, they're not going to be ready to move on to any actual eating tasks. So we're going to work on regulation here at this mode. A lot of times in this, we're going to also team with as many different physicians who are on your child's team as possible. We're going to get information from surgeons, pediatricians, gastroenterologists, whoever we can sort of team with to get as much information as we can. The next thing that we look at is nutrition, because nutrition is the foundation for growth and development. So whether the child is eating by mouth or through a tube, we want to make sure that they are getting the optimal nutrition that they need so that they can continue to grow and develop. They need to have good nutrition in order to kind of fuel their gross motor, fine motor skill development, and then their overall health and wellness. Then we start to look at some psychosocial factors. There are a lot of times with traumatic brain injury and being in a hospital, kids have a lot of negative experiences related to things coming near their face and mouth. And so we want to kind of look at what their relationship and their behaviors are in relation to the actual feeding process. Sometimes we might work with a mental health provider to kind of address some of those. But if not, then we're going to just work on building some engagement and enjoyment there. And then we look at the parent-caregiver relationship. Feeding is kind of a give and take from both sides, and both the parents and the kids come to the table with different skills, different experiences, different abilities. So we want to make sure that there is a relationship of trust there, and that there's a good kind of reading of cues and things like that during the feeding process. And then we start to look at some environmental factors. We might ask about your daily mealtime routines, what your schedules look like. We know that we want to try to establish a feeding schedule as much as possible. For kids who are on tube feeds, a lot of times they have a schedule established by their physician. But if they are oral eaters, we want to kind of start to achieve that schedule so that we can build and normalize their hunger cycle, so that when we come for meal times, we're actually hungry and associating that with actually eating. And then we start to look at their sensory processing. And so this is where we want to find out if they have any oral sensory aversions that are contributing to their feeding disorder. There may be aversions to textures, temperatures, tastes. So we're going to kind of evaluate all of that. A lot of times we get a food list of the foods that they like to eat so that we can see if there's any patterns there. If they're tube fed, they're not eating by mouth, we're going to kind of explore with their mouth a little bit just to kind of see what their responses are, how they're feeling about things going near their mouth. And then finally, at the very top, that's when we start to get to the motor coordination and actual oral motor skills, working on their chewing and that type of thing. We also, at this point, want to make sure that we have really good core and trunk support so that they can focus their motor skills on actually eating during that process. And we want to try to set them up to be as safe and efficient as possible. So I'm going to talk a little bit about aspiration. Like we talked about in the normal phases of swallowing, there are a lot of components to the swallow. So it actually takes 13 pairs of muscles and 6 cranial nerves working at the same time to try to move that food and liquid through the body. So anytime an error occurs in this coordination of this system, it's considered what we call dysphagia, or a swallowing problem, and may result in aspiration. So aspiration sounds like a very scary term for a lot of people. It just means that something has entered your airway or lungs by accident. It might be food, it might be liquid, it might be reflux that has come back up. And a lot of people are always worried about aspiration pneumonia. You're gonna hear me say this several times. Large amounts of aspiration might cause aspiration pneumonia, but not always. We'll talk a little bit on the next slide about some factors that are gonna predict pneumonia, but just because aspiration occurs, it does not mean that aspiration pneumonia is going to occur. All of us as typical swallowers aspirate fairly frequently on our own. You probably have coughed while you're drinking or things like that. There are just times that happens accidentally. The coordination gets a little bit off, and we are all healthy after that. So we're going to talk a little bit on the next slide about the factors that are impacting or predicting pneumonia. We're going to look at the immune system status, whether it's normal or compromised, the oral health status, whether it's healthy or unhealthy, and then laryngeal valve integrity just is referring to whether there is aspiration occurring or not occurring, and we would know this through a swallow study. So this chart shows us a combination of all of those risk factors, whether the immune system is normal or compromised, whether the health status is healthy or unhealthy, and then whether or not aspiration is occurring. So you can see on this chart that of these 7 possible combinations of things, only one of them is actually a risk for pneumonia, and that's when our immune system is already compromised we have unhealthy kind of oral health status, and we have shown history of aspiration. So that's when we're really worried about these kids aspirating. The percentage of people that will actually get aspiration pneumonia is quite low. How does the brain injury affect feeding and eating? So we know that most children with a severe acquired brain injury will have feeding difficulties, especially in the early stages of recovery. Depending on where the injury occurs, how severe it was, what their level of consciousness or alertness after the injury are, and how long they were under sedation can impact what their feeding and eating skills look like after the injury. Something else to sort of keep in mind is that taste and smell are super important components of eating. They trigger saliva production and get the body ready for eating. So if the areas of the brain related to taste and smell are injured, this can affect their ability to prepare their body for eating and can impact their swallowing as well. Some other things that we might see are just cognitive deficits where the child just maybe doesn't even understand what eating is or what to do with food when we present it to them. And then sometimes we also have some behavioral problems. So a lot of times the most commonly seen problems, the way that we see this look, is just reduced muscle coordination and difficulty moving the food around in their mouth, getting it ready to swallow. Sometimes we see a delayed triggering of the swallow reflex, which is meaning that the food is starting to enter the throat and the swallow doesn't trigger to close off the airway and all of those things quite as quickly as we would like it to. So sometimes that food can fall into the airway a little more quickly. Sometimes they can be totally safe with a delayed swallowing reflex. And then we sometimes see just poor movement of the food through the mouth and the throat. So a lot of the kids that actually aspirate do have an intact swallowing reflex. It's usually just difficulty with coordination of the oral structures and actually closing off the airway and things like that. There are a small subset of kids who do present with an absent swallowing reflex after a brain injury, and that's going to take quite a bit longer to heal. So we're going to start talking about what treatment should look like. We're going to talk about motor learning and neuroplasticity. Neuroplasticity just refers to the ability of the brain to change, and motor learning is a method of training in order to facilitate that neuroplasticity. And we know that neuroplasticity is best induced when the movement that we're doing is purposeful and actually related to the behavior being trained. So we want to really work on the actual feeding tasks in order to build those skills for feeding. A very important concept in feeding and eating recovery is use it or lose it. The muscles of the throat and the mouth can atrophy very quickly when they're not being used. So we want to try to limit NPO, which means nothing by mouth. We want to limit those recommendations as often as possible, because if they're not taking things in their mouth, they're not using those muscles, and we can have atrophy of those muscles. So we want to try to provide safe opportunities whenever possible, even if it's practiced with tiny, tiny sips of water or saliva only, just to work on that swallow reflex. There is a lot of people will go to a swallow study and see aspiration and immediately put the child on NPO recommendations. However, for children who have gone into the swallow study who have been eating by mouth and haven't been sick prior to the swallow study, but show aspiration only on the swallow study, we might actually do more harm than good by not allowing them to eat just because they showed that one moment of aspiration. It's, like I said earlier, that's just a very short moment in time. So just because it happened that one time doesn't mean it's happening all the time. So we can proceed with caution on giving them some opportunities to eat by mouth. The actual tolerance for how much you can aspirate before you actually get aspiration pneumonia is variable depending on the person and depending on the other factors that they have. Again, aspiration does not always lead to aspiration pneumonia. One of the big factors with brain injuries is that we want to start early. We want to start As soon as children are medically stable and cleared by their doctors, we want to get in there and start doing an evaluation and start some treatment as quickly as we can. So we don't want to unnecessarily delay the introduction of any opportunities just because there is a neurodisability. So a lot of times the younger nervous systems or the freshest post-injury are more responsive to training and adaptive neuroplasticity. We're going to talk a little bit about some of the components of therapy that are related to environmental arrangement in order to optimize progress. So the first thing is that kids learn best when they're having fun, when they're focused, when they're enjoying what they're doing. So we want to try to make meal times as enjoyable and interesting as we can. We're going to try to limit as many distractions as we can and use that hunger as a motivator to get them engaged in the mealtime. Sometimes if they have some behaviors or difficulty sort of participating in that mealtime, some aversion to it, we're going to try to use some of those regulation strategies to try to get them calm and ready to participate in that mealtime. A lot of times children who have difficulty eating demonstrate some avoidance behaviors because it's hard for them. So they're going to be wanting to look at a screen, they're going to be wanting to turn away, and it's really easy to provide some distractions during that time to try to keep them engaged while you feed them. But we really want them to try to be an active participant as much as possible. So we might have to take some steps back, build that regulation and that engagement, and then start moving forward. A lot of times we have to trial also modifying their feeding schedules, especially with tube feeding. Those children have kind of a constant feeling of fullness. They're getting enough nutrition to meet their needs all the time, so they don't know how to work with those hunger cues quite yet. So sometimes we might have to modify their feeding schedule a little bit to try to work and utilize that hunger to our advantage. We also know that children learn best when the task that they're doing is rewarding and meaningful. So typically at the beginning, we're going to use really highly motivating foods, low pressure exploration, let them play. We want to build those positive interactions with the mealtime. At this point in the treatment, we are not worried about introducing new food, trying to change foods. We just want to get them as much food as they can enjoy participating with. And we're going to try to, we'll talk about this a little bit more later, but we're going to try to minimize the use of tools, equipment, isolated exercises, and clinical settings as much as possible. We want to try to get to as natural of a setting as we can. We also know that children learn best when the skills are applicable to their daily life. So we want to try to use practice in home, in daily routines with typical foods and utensils and all of that as much as possible. This means that we are going to teach you in therapy, and we're going to encourage you to do it at home as much as possible, because that is where the children are going to be most comfortable and participate. So we also know that children actually learn best by actually doing the skill and figuring it out themselves rather than just being taught what they're supposed to do. So we want to encourage kids to be a part of our mealtime so that they can kind of see what routines are, they can get some exposure to different foods, they can be a part of the smell, see how people are using their motor skills. But just sitting there and being a participant in the mealtime is not going to actually teach them the movements that they need to actually eat. So we want to try to use actual food, natural environments, actual mealtime contexts as much as possible. We might have to make some modifications to facilitate success. We might modify the size of the piece that we're giving them, the textures based on their sort of sensory abilities, how quickly or slowly we're feeding them, and then give them some postural support if we need to. So we also know that kids learn best when the context of the practice varies. So we know that kids thrive with routines, and routines are super important for a lot of daily routines and meal times, but we also don't want our children to be so rigid in their feeding routines that they can't generalize the skills to other locations. A lot of times there are a lot of kids who will only eat for a certain parent in a certain chair with a certain utensil at a certain time with perfect food, and we want to try to encourage as much variety at the beginning as we can so that we don't get stuck in that sort of rigid routine. And like I talked about earlier with home practice, Kids learn best by practicing a lot, so we want to provide as many opportunities at home to practice as we can. So your therapist will help you work on some home programming to kind of figure out how you guys can best practice at home. This little visual shows us that there are 168 hours in a week, and therapy is typically one of those hours. So if we are not doing anything at home, we're not going to see that carry over in that progress. So the most important factor in the rate and progress of therapy is how often you guys practice at home. This doesn't mean that like every mealtime has to be a therapy session, but we want you to try to integrate it as often as possible. So now we're going to talk about some actual therapy tasks, some of our guidelines for creating therapy tasks during therapy and home practice. Like I talked about, they learn best when they're completing the actual feeding task. So if I'm trying to work on chewing, I'm not going to just work on chewing with a chewy tube, one of these little red tubes, because that's not going to translate to chewing with a piece of food. There are a lot of other components that go into actually chewing, managing all that food. Your saliva is going to increase, your muscles are going to work differently. So we want to try to limit the use of just tools as much as possible. Sometimes we might do it briefly, sometimes we might dip that tool into some food to kind of build up that idea of chewing, but we want to try to transition away from that as much as possible and work on that actual complete whole feeding task. We also want to try to make it as complex as they can achieve with support. So we want to kind of work in what we call their zone of proximal development, which is the level just above what they can do on their own, what they can sort of achieve with some adult assistance. So if we are pushing them just a little bit and they can achieve that skill with our help, then that's where we're really going to see some motor learning and progress. If we're kind of working on the same skills at the level that they're able to do by themselves without any assistance, we're not going to be progressing in our actual skills. And then we also want to practice tasks very similar to the goal. So like I said earlier, we want to use the foods that you're actually using at home. We want to try to practice at home as much as possible. We want to try to mimic that mealtime. Even if it's in therapy, we're going to try to mimic what you guys do at home to build those motor skills and then help you guys transition those skills home. We also want to work on multiple targets randomly. So sometimes at the beginning, when we're learning to eat a new food, we're going to do lots of trials of that same food over and over again so that they can build that motor plan. But over time, we want to start introducing a variety of foods in different orders. So we might give a bite of toast, and then we give a piece of apple, and then we give some applesauce, and then we take a drink of milk. We want to kind of mix it up because that's what more mimics a natural mealtime than just eating all of one food, all of the next food. So we want to kind of keep their oral motor skills adapting very quickly to the order of food that we're giving them. We also want to practice a lot at first and then start spreading our practice out in order to generalize. So this is just kind of a sample week, and you can see that the gray spots are massed practice. So that might be like a therapy session or a therapy snack time at home. We are going to do a lot of practice all at once to try to build those skills. And then as soon as they're able to start to generalize those skills, we want to start distributing that practice, small opportunities all throughout the day, different times of day, so that they can start to generalize to a variety of different contexts. The biggest thing that we don't want is the child to only do it in therapy and not be able to do it anywhere else. So when we're talking about feedback, we want to provide feedback that is ultimately intermittent and focused on the results that we are looking to achieve. So at the beginning, we might really give a lot of frequent feedback about exactly the motor thing that they're doing. So, hey, you just moved that cracker onto your side teeth with your tongue. That's very specific immediately after they did that motor movement so they can start to associate what they did in their mouth. And then over time, we want to kind of fade that out, give a little bit of a delay, and make it a more general feedback. So, wow, you ate that whole cracker. We want to help them become a little bit less prompt dependent to complete the task. So these are a couple of quotes that are just about motor learning. So repetitions are essential for the acquisition of motor skills. The most important variable in a training program has been found to be the amount of practice. And the best practice task for acquiring and improving eating skills is a natural eating practice task. We're going to talk a little bit about some different therapy approaches, different tools you might have seen, different modalities that are available. So this is a question we as therapists get a lot. Should I buy this certain specific tool? Should I use this specific spoon? The answer is that it is unlikely, based on research, that only using a specific tool, doing a specific stretching exercise, something passive, is not going to actually improve their oral motor skills. There are a lot of really cool looking techniques that are out there that you might see on social media, things like that, that look like a lot of massages, moving the kid's mouth around. Those can sometimes help, but that is not going to improve their actual eating skills because it doesn't really generalize, like I said, to the eating task. We want to try to use functional activities as much as possible. This little flow chart sort of gives us an idea of where to start. So we want to first think about if the child is safe to eat by mouth. If they are not, if they are completely NPO, which I said is a very small portion of our children, we want to start with just building their comfort and enjoyment around meal times. We want to get them excited about participating in that mealtime. And for these children, we may provide some tools or they can even be home teethers, anything like that, to work on some mouthing and chewing just to increase exposure to what's in our mouth and decrease some of that sensitivity, increase our awareness. The most important thing to keep in mind is that we always want to encourage intrinsic motivation. We want that child to be trying to do it themselves, be accepting of what we're doing. Anytime we are forcing something in their mouth, they're going to be a little bit aversive, and you're going to ruin that trust that you've worked on building. If the child is safe to eat by mouth but has some sensory aversions, again, we're going to start with building that comfort and enjoyment around meal times, and then we're going to start practicing with real food and meal times as soon as possible. And then if the child is safe to eat by mouth and they don't have any aversions, we're going to jump right into real food and meal times as much as possible. These are some therapy techniques that you may see during therapy sessions. These are things that we're thinking about doing to sort of modify the feeding activity for the patient in order to build their ability to participate. So we're going to use some participation approaches just to increase their engagement and motivation. It might be food play, it might be reading books about food, it might be playing with pretend food, cooking activities, getting them in the kitchen while you're cooking, just building that desire to participate with food. We might do some specific seating or positioning changes. Like I was mentioning earlier, we want their alignment as optimal as possible so that they can really focus on using the muscles of their mouth. So we might use towels, an adaptive chair, just position them a little bit differently so that they look as safe and comfortable as possible. We occasionally use some specific feeding tools or utensils or drinking vessels just to improve their efficiency. I'm going to talk in a little bit about just some of the tools that we might use, but we're not using these to fix the problem. We're just trying to help them sort of adapt to whatever sort of impairments that they have. We might make some modifications to the sensory properties of the food just to engage their oral motor response. A lot of times kids who have had a lot of tubes or things in their mouth might be a little bit hypersensitive and don't want really strong flavors or things like that in their mouth. Sometimes they are hyposensitive. They're so used to things being in their mouth that they need a lot of input in order to actually feel what's in there. So we might add spices, we might change the temperature, we might change the size of the bite, we might give them something really crunchy, something like that, to help them feel that a little bit better. And then sometimes we do some food placement techniques in order to get the oral movements that we're looking for. So like if we're working on chewing, sometimes when we put that bite in the center of their mouth, they don't necessarily feel that bite or know what to do with it. We might put a bite directly onto their teeth so that they can initiate that chewing. So these are just some therapy approaches that you may have heard of. I've sort of grouped them here just so you have some understanding of what they sort of address. Some of the mealtime participation approaches are SOS, AEIOU, the get permission approach, and division of responsibility. I'm not going to go into the details of any of these, but just for your awareness of what is out there. And then some of the approaches for oral motor would be Beckman oral motor or the SOFI model, which is more for infants. These are some of the feeding utensils that you might see. These are some things that we find helpful in feeding therapy. The first one is a Chew Me spoon. This is great for self-feeding. There's not a right side up or right side down, so especially when we're self-feeding, we don't have to work on the coordination of getting that in there correctly. The food just kind of sticks in the middle and they can put it in there and kind of suck on it for some early spoon feeding. The next is the Ola baby spoon. This is a soft silicone spoon. It's real flat. It's easy for kids to kind of get in their mouth and get the food off of. It is great for kids who have that tonic bite reflex. When you put things in their mouth and they bite down, we don't want a hard plastic fork or a metal fork in there. We want something nice and soft for them. These are chewy tubes. Like I talked about earlier, these are not going to be helpful in isolation for improving our chewing, but we might dip them into food to give them some feedback as they're chewing. This is a reflow cup. This is a great cup for teaching open cup drinking skills. It has a little insert that goes in the top and really slows down the flow of liquid. So when they tip that cup up, it's not going to come all rushing at them. It feels very similar to an open cup, and so it's a great substitution for them. Over here on the side, we have what's called the sip tip, and this is, it's a flow valve. So it's going to slow down how quickly they can take in that liquid through the straw. It also kind of limits the amount that can go in. So for a kid who's going to suck and suck and suck and get too much, this is a great option. We have nosy cups. These are great cups for teaching cup drinking. They are pretty flexible, so you can fit them well into their mouths. And they also have a nice little cutout, so when we're tipping the cup up, we're not bumping the top of the cup into their nasal bridge. We have a little bit more room to move it. This is an easy peasy cup. This is a great cup for learning cup drinking. It's got a very heavy bottom, so it gives a little bit of feedback as they're lifting it, and it also kind of stays balanced a little bit better than most cups. And then we have the Honey Bear. This is a great tool for teaching straw drinking. When the straw fits into the lid, it forms like a really tight seal so that when we squeeze it, just like a juice box, the liquid's going to come straight up through the straw. So when we put that straw in their mouth, we can give them a little bit of a squeeze and they can start to make that association that liquid is coming through the straw. And then eventually they can use it just like a regular straw cup. So we're going to talk a little bit about neuromuscular electrical stimulation, most commonly known as vital stim. You've probably heard this for feeding and swallowing. This is not a miracle cure. It's not indicated for all children, but it is an innovative, non-traditional tool that we use in conjunction with our traditional therapy approaches. This is not going to do anything if you just put it on by itself and leave it. We have to really do some feeding therapy with it. It uses a small current passing through some electrodes. We put them either on the throat or on the cheeks, depending on what the muscle need we have is. And it's going to stimulate those swallowing muscles. It's going to provide gentle contractions of the muscles so that they can start to associate that as they are eating and drinking. There are some downsides. It can be invasive and uncomfortable. It doesn't hurt. It's just kind of a weird feeling. You feel your muscles contracting. And especially for kids who are a little bit sensory aversive, they might not like stickers on their face and neck. And Vital Stim can only be administered by a certified Vital Stim practitioner. So that's something important to keep in mind.
I have a question.
Sure.
My grandson's about to have that next Thursday. So when you're saying they're going to come and do the evaluation, of course, first.
Yep.
And how long would it go for? Because I hear the word invasive all the time.
Vital Stim totally depends on the patient. We want to do it pretty frequently for a few weeks. We're going to try to do it 2 to 3 times at the very minimum per week, increasing the frequency if we can, if you have that opportunity. Sometimes we only have weekly availability. But you probably do it for about 9 to 12 weeks, and then you're going to evaluate the swallow again and see where we're kind of at, and then you can revisit later on if you need to.
Is it going to be like vibration? Is he going to feel it? Because he's real when it comes to that kind.
Yeah, so when it first turns on, you can adjust the levels of it. When it first turns on, it feels a little bit pins and needles-ish, but once you get past that point to a higher level, it starts to contract the muscles. So you just feel your muscles actually contracting. I've done it on myself, not painful, but it does kind of have a weird feeling to it if your muscles are not under your control. So it can be a little bit aversive, but a lot of times kids tolerate it very well. So, yeah.
Hi, I have a question too. So here it says the best candidates are those minimal to no aversion. So my son, he has like an aversion. You put something in his face, he's like, what would you suggest? How would we prepare prepare them, I guess, for vital STEM? Is there a way to, or would that be the therapy practices to help him just, get used to it or get more comfortable?
Yeah, that's a great question. So yes, I would go back to traditional therapy at first, build that enjoyment, that desire to be part of the mealtime. A lot of times I'll incorporate touching things to their face with their sort of permission as I can, sort of just getting them used to having things touching them. Especially like parents and caregivers. I want you guys like playing with their face, tickling them, those kind of things. I'm gonna do it a little less as their speech pathologist, but at home, you wanna do all of that kind of stuff just to get used to having things touching you. If they are really aversive, they might not be quite ready for that yet. Yeah, absolutely. We're talking a little bit about the intensive model of therapy. This is a therapeutic approach to treating children and adults that have cerebral palsy or other neurological disorders. And it is a short duration, high frequency therapy bout. I'm going to talk a little bit about what NAPA's intensive therapy program looks like on the next slide, but the best candidates with regard to feeding for the intensive model are children who have minimal to no aversion, because we can really capitalize on that motor learning and have lots of repetitions to build those motor skills. We can work with children who have oral aversion. We're going to look at some of that global improvement, that sensory processing, and we're going to give them some experience with food and meal times. But at this stage in the game, we're probably not focusing heavily on their oral motor skills. So this is NAPA. I work at NAPA. We are known for our intensive model of therapy. Our patients come for 2 to 6, 6 is kind of high, 2 to 5 hours a day, 5 days a week for 3 full weeks. During a intensive, they are receiving a variety of different therapies. So this 2 to 6 hours is not all feeding. It might be different modalities, PT, OT, speech therapist. The feeding portion, we're looking at really targeting their muscular coordination, their sensory processes, and their social experiences with eating. We do have Vital STEM, and we often use it during the intensives because we have a lot of opportunities to get a lot of sessions in with that. I will say with regard to Vital STEM, I do see, and this is not research, this is my own clinical experience, that for children who do have an absent swallowing reflex, Vital STEM doesn't always fix that. So it takes kind of a while to kind of build that back up and get that reflex that brain to heal so that reflex can kind of reintegrate. And a lot of our children gain more progress in their 3 weeks of intensive therapy than in a whole month, in 12 whole months of ongoing traditional therapy. They're getting really intensive, they're getting a ton of practice every day, and then they are kind of building those skills very quickly. And then this is some new research that's coming out. We're trying to move away from the idea of fixing a child's neurodisabilities and just working towards their optimal functioning. So we are not trying to necessarily achieve what's normal or typical for able-bodied children. We're trying to make some decisions that are going to best meet the needs of these patients. So they've categorized them into the F words of childhood disability. I'll go through those. The first one is function. So we want to really just work on their engagement and improvement of daily tasks, daily activities. So it might be mealtime, school, daily living activities. And we really want to focus, like I said earlier, on what they can do in their home environment versus a highly controlled clinical setting. We really are looking at the family component. We know that supporting a disabled child is a lot. It's a lot of work. It's a lot of time. And so we're going to try to get you the support that you need. We're going to try to give you the interventions that are going to be most beneficial without taking up your whole day. I know you're getting ideas from everybody, and it's a lot to take in. So we're going to try to really optimize that and get the help that is really going to be beneficial for you. Fitness is something that we keep in mind a lot of times, more with like PT and OT, but just keeping in mind that our children with neurodisabilities often have less access to physical fitness activities, but we want to try to incorporate that when we can. Their gross motor skills are going to directly impact the fine motor skills of their mouth, so we want to work towards improving that as well. Again, fun. Childhood should be fun. Kids learn through play. We want to incorporate play as much as we can in feeding, in daily routines. Childhood should be really fun for them. And then friends, we want to try to support peer engagement, relationship building as much as possible. I know at NAPA we have a really open concept, so the kids are passing by each other all the time. We try to get them engaged with each other, and that's really helpful in facilitating their progress. And then ultimately, future, we want to really consider what's important for them long term and really work towards those goals. And that is all I have. If you guys, does anybody have any questions? Sure.
When a child aspirates, what happens to that food?
Depending on the quantity of it, if it's a large quantity, it could cause an infection. Eventually, it will break down and make its way. Our lungs are they're air sacs, but it's a whole bunch of little. It attaches to capillaries that spread throughout the body. So it'll eventually break down and go into their bloodstream and distribute throughout their body. It takes a while. Usually it's a very small amount, so they can usually handle that, and that happens and doesn't become pneumonia. Yep. Does somebody else have a question? Yeah.
Do you recommend, or definitely not recommend, if we did like a OT-PT intensive in the morning and a speech feeding in the afternoon?
We do that all the time. Our schedules totally vary on what works best for the kids. A lot of our kids who come for feeding do all of the different modalities on the same day. Yeah, and that's totally fine. Some days, especially if you're doing all that physical in the morning, some days they are a little more fatigued for feeding, but we can totally make it work. Yeah. Anything else? Yeah.
I do, and I hope this makes sense. So my son, he also has a missing.
Uh-huh.
So just wondering, does that impact feeding in any way? Like I understand he can't really burp up foods, and it's supposed to prevent the aspiration. At some point, does that impact feeding? Like, does that have any relation to feeding? I don't know why that question just came up.
Yeah, no, that's a great question. I don't know if I know like the research on that, what that actually does. I know it may affect their hunger and fullness sort of feelings. It's keeping food in there. There's not reflux. It's probably going to help his sort of feelings after mealtime because he's not getting that reflux. He's probably going to feel better, but I don't know if there's any sort of negative association. I'd have to look more into that. Yeah. Anything else? Thank you so much. If you have any questions, this is our contact information for Napa. We also have a booth out front. If you have any questions, please stop by. And thanks.